Okay, well, good. It's 10 o'clock here in Malaysia, but let me just say a good morning, good afternoon, and a good evening to all of you, depending on where you are. My name is David McCoy. I'm a professor of global public health, formerly of Queen Mary University in London, and I'm currently now working at the International Institute for Global Health, which is part of the United Nations University, based here in Kuala Lumpur. So it's really my pleasure to be chairing this session of this incredibly interesting conference that's been put together. This session is looking at really the experiences and learnings that we can take from the research that has been done in a number of low and middle income countries in relation to the impacts of both COVID, the pandemic, and also the communicable disease control measures that have been applied to COVID. We have three excellent speakers. My plan is to allow each of them to present for 10 to 12 minutes. We will go straight into the next speaker after the first one has spoken, and we will keep questions for the end. I will start by putting some questions to the three panelists and initiate some discussion, but you're also invited to participate in the Q&A session at the end of this, at the end of the talks. And in order to be able to put your questions, you need to use the Q&A function on Zoom. Please put your questions into that facility, and we will try and do our best to accommodate as many questions as we can. Now we're going to start with Dr. Caroline Kabaria. Caroline is a postdoctoral associate research scientist at the African Population and Health Research Center based in Kenya. She's got expertise in geoinformatics, remote sensing, spatial modeling, and developing methodological frameworks to integrate spatial evaluation in a variety of impact evaluations. Her PhD focused on mapping and understanding changing malaria transmission patterns within urban settings in Africa. And prior to joining the APHRC, Caroline was a postdoc researcher at the Khemri Wellcome Trust research program. She's going to be presenting on how COVID has exacerbated marginality amongst communities living in slums in Nairobi. Caroline, over to you.
All right, thanks very much, David. I'd like to check that you can hear me and you can see my presentation.
We can hear you and we can see your presentation.
All right, so thank you very much for the introduction. I'm very happy to be joining you today from Nairobi. It's around 5 o'clock here. So today, as David has introduced, I'm going to speak about how COVID-19 has exacerbated marginality within informal settlements in Nairobi. So thinking of COVID-19 as a driver of marginality within the Nairobi informal settlements. So as a way of introductions is that slum statistics are always hidden. They're almost invisible in usual statistics, whether they're health or census. So just an example on the left that shows population growth between urban and rural areas. And this is very common where population data is always presented either as urban and rural, and it's very difficult to understand about the urban poor who live within communities in cities. And the statistics particularly affecting health for slum communities are always averaged within the urban statistics, and this can imply that slum communities are doing better than they really are. So as a way of example, on the left, on the right-hand side, I have a table that compares data from the Kenya Demographic Health Survey, showing, for example, there's some statistics, for example, looking at child mortality. So within the national average was presented at around 14%. And within the city of Nairobi, it was at 17%. But if this is compared with statistics from slums, and this is what is in the first column, coming from the Nairobi cross-sectional slum survey that was conducted by APHRC in 2012, you can see the rate is at 40%. So you can see the danger or how there is misrepresentation of slum statistics by averaging with the normal urban statistics. And the trend is the same, looking at, for example, vaccination of children, where the coverage appears very high within urban areas at 83% or 81% within the city. But within the same city, Nairobi, within slums within Nairobi, it's quite low, below 50%. And so it's therefore important to think about how the statistics of slum communities are actually represented. So the work that I'm presenting today is part of work we are conducting under the ARISE Hub. The ARISE project is a project looking at responsiveness and accountability within informal settlements. And within Kenya, it's been conducted in 3 informal settlements, which is Korogocho, Viwandani, and Mathare. And this is done in partnerships with APHRC, LVCT Health, and Slum Dwellers International Kenya, SDI Kenya. So in terms of context of how these slums look, very similar to a lot of slums within the country or within the city. They are characterized with overcrowding, poor garbage disposal, very poor drainage. In terms of access to services, a lot of them rely on public taps, for example, for water. A lot of them are not connected to sewer. A lot of them are living in temporary structures with poor roofing or wall materials or even floor materials. And looking at health service utilization within the slums. So this is data from a study we conducted, from a project that just concluded in October last year.
Hello?
And, sorry, can you hear me? All right, sorry. So, and just looking at the comparison.
Radioed already.
Preeti, can you please mute your microphone? You're being heard. Sorry, continue.
All right, sorry about that. So thinking about where slum communities or the residents of these slum communities are seeking for health services. So these are results of, as I said, from a study that just concluded last year. And as you can see in both communities, people really rely more on pharmacies or chemists, private providers, and with few utilization of, with lesser utilization of public facilities. In terms of costs, a lot of people spend out of pocket in both communities, whether it's for consultation, for medicines, and in terms of expenditure, the expenditure for consultation, medicine, transport, and or other expenses. So what does this mean? Thinking about the COVID-19 pandemic. So we conducted a study sometime last year, and we were talking to slum dwellers, communities living in informal settlements, trying to understand how the pandemic has impacted them, particularly in terms of access to health. So the first thing that, like the top result we get, is that there was a loss of livelihood because of the forced lockdown and restriction on movement. And this is because a lot of the communities here rely on the informal sector. As you can see, a lot of people are in the informal sector. So asking them to stay at home actually meant them losing their jobs and their sources of livelihood. And as you can see from the excerpt on the right-hand side, one of the participants says that women were hardest hit by the COVID-19 pandemic because they are primary caregivers of individuals who are ill during the pandemic. And most of the time, women are not decision makers in their families, and as such, the money they find in a day ends up in the hands of men within their families. Another observation that we found in these communities is that the pandemic disrupted access to healthcare. And as I had already discussed before, that the immunization levels, for example, are usually quite low. And that is shown in the map we are seeing there. So this is Korogocho community, where if you are to look about think about the urban average, so you can see there's a sub-county here called Ruaraka, where the coverage seems to be very high for immunization at 80%. But if you compare with the slum communities, you can see all the villages within Korogocho, for example, are all below 40%. And so the pandemic made it worse. And just by way of example from the excerpt there, that some health services were compromised during the COVID-19 pandemic. Services like mother and child services, even clinics, there were many defaulters as mothers feared visiting the health facilities. Some referral facilities were also overburdened during the outbreak, then hindering access to services. So this was a community health volunteer discussing how the pandemic has disrupted access to healthcare. Another issue that came up was about the lack of information on how regarding the pandemic. And so, for example, children were reported to have limited access to timely information on the pandemic, and many were unable to express their fears and anxieties. So some mental health challenges. Thinking about persons with disabilities are easily isolated in access to information during the pandemic, particularly given how the message was being communicated. Many are hearing or visually impaired, and then this limits what information they're able to get, including even other basic services. At the same time, elderly persons also had a difficulty accessing information related to COVID-19, and because they would need somebody to accompany them to health facilities, which reduces social distancing, and many of them were categorized as a population at risk. And many people, particularly within the informal settlements, are also illiterate and not able to interpret the COVID-19 messaging that was going on in that community. So other challenges that again were identified in this community, some of them are related to the COVID-19 pandemic. Some existed before, but maybe became worse. So people complained about the long distances to the health facilities, or that there were inadequate service providers. Sometimes the services were not affordable, and we saw that a lot of people are relying on out-of-pocket expenditure. There were long queues, or people lacked the knowledge about where to seek health services. I'm quickly just going over, I want to go through everything. So thinking about inclusion, there was a feeling of, for example, discrimination or denial to access facilities. The facilities themselves were not accommodating people with special needs, like persons with disabilities. Language barrier sometimes was identified as an issue. There was also safety concerns. A lot of people avoiding hospitals because they were afraid they'd get infected. There was a lot of misinformation on health practices within the community. And general physical security was also a concern, particularly at night. So some of them existed before, but maybe others became worse during the pandemic. So then what are the policy and the pragmatic implications? So some of the things that came out thinking about the results I've just presented is that there's a need for financial and social risk protection innovations due to the high out-of-pocket expenditure. It is also necessary to collaborate with other sectors. So health systems or health practitioners need to think about collaborations with other sectors. So for example, hand washing was a basic preventative measure for COVID-19. And thinking about slum communities, then what is availability of hand washing facilities? What is the availability of water and soap within these communities? It was also then important. It's also important then to empower low-level health managers to be involved within the policy and decision-making processes. So more of a bottom-up approach versus a top-down, thinking about information to communities and so on. Then it's also important to empower communities to demand for accountability from leaders or service providers, and a bit of a call for implementation research on how you can improve quality of primary health care and linkages with allied and tertiary services. So in my last slide, and this is in a way of conclusion, just to make the emphasis that it's important to always disaggregate the deprivation burden of slum residents, because then it makes it easier to highlight the issues for people who are living in these communities. And it helps policymakers to also focus on what is important or what is relevant to the communities. Because a lot of urban programming is usually done at local level, then it means we actually need disaggregated data and particularly in Kenya, where we currently have a devolved system. So that brings me to the end of my presentation. I'd like to acknowledge the funding from GCRF, UKRI for this funding, our partners in ARISE, both globally in Bangladesh, India, Sierra Leone, and our local partners, LVCT and SDI Kenya. That brings me to the end of my presentation. Thank you, David. Over to you.
Thank you, Caroline, and thank you especially for being completely on time, if not under time. Given that you were so punctual, if you don't mind, I'd just like to ask you one question just to help contextualize some of what you presented. And perhaps, and it's really asking you if you could perhaps give us some idea of the kind of measures that were being implemented in these slum areas in terms of lockdown measures, and what efforts were put in place to try and mitigate the impacts of those measures. You know, how severe were the lockdown measures in these areas, and to what extent were they adhered to, and what efforts did the government make to mitigate them? So you're muted, Caroline.
All right. So in terms of measures that were implemented, they were not slum specific. They were actually country. So there was a full lockdown of the city. So thinking about restriction of movement in and out of the city, but people are allowed to move within the city. But then there was also control of time. So there were like nighttime curfews where people are not allowed to move after a certain hour. A lot of organizations and companies were forced to close down. And as I said, this will negatively impacted the communities because a lot of them are informal sector workers. So if you ask them to stay at home or work from home, if I work in the market, it's not possible for me to sell in my house. It's not possible for me, if I'm a construction worker, to say that I'm working from home. So this really actually impacted these communities. In terms of access to services, it was interesting because government particularly targeted slum communities with supply of water. And it's interesting from some of our interviews where people say that they actually observed improved services, more hand washing or water being available to the communities than before the pandemic. And that is something that they can hope that maybe can be sustained. So government did try to provide water and hand washing facilities, maybe through public taps or water bowsers. I think that's it. I'm not sorry if I've missed something else.
No, that's fine. Thank you, Caroline. That was helpful to contextualize some of what you were presenting. If you could just stop sharing your screen, please, Caroline. Our next speaker is Dr. Brunah Schall. Brunah is a biologist with a PhD in sociology. She's currently a postdoc scholar at Fiocruz, Minas, part of the Oswaldo Cruz Foundation in Brazil. And Brunah's got lots of experience conducting sociological qualitative research and is currently working with gender and vector control in the Brazilian context. And she will be presenting some of her findings looking at the impact of COVID on sexual and reproductive health in Brazil. So welcome, Brunah, and over to you.
Hello, thank you, David. Can you see my presentation and hear me?
Yes, we can.
Okay. Good morning from Brazil. Thank you for the invitation to speak at this event. So I'm going to talk about sexual and reproductive health during the COVID-19 pandemic in Brazil. My slide is not moving. Why is that? Some technical problem here.
Can we help you?
I will stop sharing and share it again to see if it works.
Do you want to go to Windows? Yeah, and then see if it works.
Okay, now it works. Sorry about that. So first, I'm going to give a quick presentation of the context of the pandemic in Brazil. Just a second, I'm having some issues here. Sorry. I lost my, okay, now. So Brazil is one of the epicenters of the pandemic in the world, but it's also one of the countries that vaccinated the most, thanks to the population willingness to vaccinate. Because of that, cases started to drop, but recently went up again with Omicron variant, as in the rest of Latin America. Recently, we started the vaccination of children after controversies and fake news involving the government, especially the president. One of the most shocking statistics in the country is the number of maternal deaths caused by COVID-19. 10% of pregnant women deaths in 2021 were caused by COVID-19. This is one of the highest fatality rates in the world and is considered a sentinel event, an event that indicates that a whole line of care has failed women, starting before they get pregnant. This shows how fragile our health system is right now. And this is mainly related to the political context that started with several neoliberal reforms in 2016 that reduced investments in the national health system called SUS. Also, the federal government.
Sorry, Bruna, is the slides meant to move? Because it's not moving on the screen.
Oh, really? For me, it moved.
So maybe we get IT to share the screen? Share the
Dr. Bruna, we're gonna share your slides.
Okay, thank you.
Apologies for the interference, but that just makes it helpful.
Yeah, I don't know what's happening.
Please bear with us. We have 151 participants listening eagerly, so I thought we could sort this out. Give us a few minutes. Thank you.
Thank you, Sabina.
We can put on window? Great. Okay, thank you.
Some small changes in this presentation, but it's fine. I'll talk about it.
Just tell us when you say next, people will move the slide.
Okay, so next. So yes, this slide I was talking about our political context.
Can you click on the buttons? There's a big red box there, Unubal. Can we click on that? So that goes? Yeah, thank you. Sorry, thank you. I'll shut up now.
Okay, thank you, Sabina. So I was talking about how the federal government, represented by the President Jair Bolsonaro, failed to lead the coordinated response to the pandemic, and besides this incompetence, he deliberately helped to disseminate the virus by promoting herd immunity and the use of medications that have no scientific support. This led to a huge number of cases that the public health system was unable to support, with the lack of intensive care unit beds and a scarcity of essential supplies for hospital care. Next. So in this context, we started to research several themes related to gender and COVID-19 as part of an international project funded by Gates Foundation and coordinated in Brazil by Fiocruz, Minas, in partnership with a diversity of national scholars, institutions, and networks. In this presentation, I'm going to focus on the theme of sexual and reproductive health of women, which is being researched by the group Gender, Reproduction, and Justice, RepGen, created in 2009, and coordinated by Cláudia Bonan and Ana Paula dos Reis. This group is composed mainly by women, researchers, and activists in sexual and reproductive rights. Next. They developed an online survey that was open from July 15 to October 31, 2021. The main question of the survey were how the pandemic affected women's reproductive planning and access to SRH in Brazil, and what are the inequalities involved in this. This research has an activist perspective of producing data to influence public policy in a context of science denialism and data blackout, as the last national public survey about SRH was in 2006. The survey had 210 questions, and women responded to a different number of questions according to their trajectories. There was an identification section, 2 SRH sections, one about preventing and tracking exams, breast and cervical cancer, HIV and infertility, and one about contraception, pregnancy, childbirth, and abortion. And finally, a pandemic session about COVID-related care. At the end, there were 2 open questions, one for general comments and one to give context to participate in the qualitative phase. 10,405 women replied and 8,384 questionnaires were valid, completely answered. 1,963 women replied to the open questions and 3,859 women said they want to participate in the qualitative phase and gave their contacts. Next, please. Next slide, please. Yeah. So to reach this great number of women, the group had several communication strategies using social media and traditional media and trying to reach women that didn't have the profile that usually replies, which is white women from high social classes and highly educated. The main challenge was to reach women with difficult access to internet, such as indigenous women, quilombolas in rural areas, and low-income women. Many women use the open question to unburden their stories. This called the attention to an unfulfilled desire to register and share what they are living. Also, there was the impossibility to contact all women in the qualitative phase. Because of these 2 points, the group decided to invite women who gave their contacts to share publicly their experiences using a pseudonym. A blog was created with this purpose called Juntas na Pandemia, that can be translated as Together in the Pandemic. The stories shared in the survey were not published for ethical reasons, so the women were asked to share again their stories by email, now with the purpose of publishing them in the blog. 82 testimonials were received, and now the blog is open to anyone who wants to post their testimonials. Next slide, please. Yeah. The research is now in the phase of statistical analysis, still in progress, but there are some preliminary results from the platform used for the survey called RedCap. Here are some of the emerging themes from the commentaries in the open questions. Reduced closure of SRH services, reduced number of SRH professionals, alteration of menstrual cycle, lack of sexual desire, interruption of investigations and treatment of breast and cervical cancer, interruption of infertility treatment and investigation, difficulties in accessing prenatal services, overload of domestic work, fear of contamination, lack of information, misinformation and fake news, impact on mental health, domestic violence, loneliness, uncertainty about the future, and unemployment. There will be more in-depth cross-cut analysis in all these themes according to race, color, ethnicity, physical conditions such as disabilities, differences between private and public health services, and regional differences. Also, qualitative interviews will be made to deepen these questions. Next, please. As an illustration of the survey data, I will focus on the preliminary results about breast pathology. On this topic, women were asked the following questions. Before the pandemic, did you do any follow-up to investigate or treat cyst, nodule, or breast cancer? 2,250 women said yes, from the total of 8,384 answers. The women who answered yes to this question were asked to specify between the following options. Yes, but I interrupted when the pandemic started. Yes, and I continue to do it with no difficulties during the pandemic. Yes, and I continue to do it with difficulties during the pandemic. And I started to investigate or treat during the pandemic because I manifested the problem. It is alarming to see that a lot of women interrupted or had difficulties in their investigations or treatments of breast pathology. Next, please. These women were asked to specify why they stopped or found it difficult to investigate or treat breast problems, and they could mark more than one option. The majority replied that the reason was fear of getting COVID-19 in the health service, followed by health services closure or with reduced hours because of the pandemic. These two answers are also being observed in questions about other SRH issues, such as investigation and treatment of cervical cancer and infertility, treatment of gynecological problems, and prenatal consultations. Next, please. So to end my presentation, here are some of the learnings we had so far. In order to act and correct mistakes, it is important to have data about what is going on and to have that data as fast as possible. Working with the hypothesis that the fear to go to the health services was highly related to lack of information or misinformation, fake news and denialism, it is important to circulate qualified information. During the pandemic, the SRH services need to be reorganized and patients should be treated accordingly with the needs of each case. In some cases, time is everything, to treat the cancer in early stages or to treat the problem before it becomes cancer. I included some more topics that are not in the slide. So some consultations can be done by distance using phone or internet, and medications can be sent by mail. Some cancer treatment protocols can be changed to do treatment before the surgery, reducing the exposure of the patient in hospitals. And finally, it is important to keep a memory of the situation and to open spaces for women to share their experiences. So that's it. Thank you.
Thank you, Brunah. Do you mind if we stop? Can we stop sharing the screen? Thanks, Brunah, once again. Maybe just one very quick question for you. Do you have any preliminary results looking at the differences between urban areas, peri-urban areas, or formal and informal settlements? Do you have any clue, just picking up on what Caroline was presenting earlier, anything about those informal settlements which exist in Brazil?
We have some preliminary, not specific about the difference between rural and urban, but there is a lot of difference in different regions in Brazil. Brazil is very diverse and big. So the north region, the results are much worse than the south, but we haven't yet looked at the rural and urban differences. But in the north region, there are more rural areas than in the south. So probably this will be a result.
Right, and informal settlements within urban areas?
Yeah, we haven't looked at that yet. We still need to.
Okay.
But
okay,
probably,
thank you.
I'm sure about it.
Yeah. Okay. Thanks, Brunah. Okay. So for our third speaker, we've got Dr. Salim Raihan. Salim is a professor of economics at the University of Dhaka. He's also the executive director of the South Asian Network on Economic Modeling. Salim has a doctorate from the University of Manchester and possesses large amounts of expertise and experience in conducting empirical research on international trade, economic growth, labor market policies, political economy, and also climate change issues. He's worked for several national and international organizations, including the Asian Development Bank, the World Bank, the Commonwealth Secretariat, the European Commission, and the ILO. And he's going to be presenting, I think, quite a broad overview, looking at the effects of the pandemic on lives and livelihoods in Bangladesh, looking at the policy responses and their effectiveness, and thinking about how COVID-19 may transform the economy, state, and society in Bangladesh. Over to you, Salim. Thank you.
Thank you. Thank you very much, David. I hope you can hear me well.
We can.
Thank you. I must thank the organizers for giving me this opportunity to share some of the views of mine. And as David said, though I'll be trying to cover 3 basic questions in the next 10 minutes or so. But I'll be trying to be specific and brief. And whatever I'll be saying, it will be very much based on the kind of research we have done at SANEM, and not only at SANEM, but also some of the surveys which have been conducted by other think tanks in Bangladesh. So the first question I thought that I should actually focus on that, what do we actually really know about the effects of pandemic on lives and livelihoods in Bangladesh? So I would focus on what I call that, what I say that we need to focus on PI, what is happening to PI, poverty, inequality, and employment. There is a very kind of natural tendency among the policymakers to focus on mostly on the economic growth aspect. But if we really want to look at the lives and livelihoods, we need to really see what is happening on poverty, inequality, and employment. And on these three aspects of development, we have seen that in Bangladesh there have been some very significant effects, negative effects of pandemic. SANEM back in December 2020, and also we continued in 2021 January, and we conducted two major surveys. One was focusing on the it was a kind of panel survey because we surveyed 10,000 households back in 2018 with the assistance of Planning Commission in Bangladesh, and by the end of 2020 we wanted to go back to the same set of households. And actually, we could cover almost 60% of the households in the survey. So around 6,000 households is surveyed. And then again, in a month or so, we surveyed another 2,500 households to look at the labor market impact. So, and also some other organizations in Bangladesh, BRAG, BIGD, and PPRC, they also conducted similar kind of surveys, repeated surveys. So what we observed that there was a sudden jump in poverty rate in Bangladesh, especially due to the lockdown measures and several other restriction measures, and also due to the various reasons where we have seen that economic activities were seriously affected. So, which also led to important implication, negative implication on the employment as well as on the inequality. Especially if we talk about inequality, it's not only the income inequality. We also saw that the education sector is still badly hit, and health sector as well, where poor people, and also what we observed, new poor, especially a large number of new people who emerged during this COVID, they are very much left out in this whole process. So now the issue is how so that is one thing. So that's what on my PI aspect, poverty, inequality, and employment. But the other aspect, what we also try to cover, through our surveys, repeated surveys by SANEM, we have been doing quarterly surveys of economic activities of firms in Bangladesh, covering manufacturing and service sectors firm, and we have been surveying around 500 firms on a quarterly basis, and we are trying to understand the kind of recovery process what is happening during COVID. So what we observed that, as I have said, on the social front, with respect to poverty, inequality, and employment, we have seen some severe impact. Though there are cases, since there is no kind of updated survey, and we have requested the official government statistics office to conduct some updated surveys, but we haven't seen much of it. So what our understanding is that probably there have been some improvements, especially with the process of economic recovery, but still a large number of people, old poor, new poor, they are also under stress. Now on the business survey, what we found that though government has come up with a significant amount of, that is my second question, on what has been the policy response. The policy response, one was that government actually tried to expand its social protection programs to address mostly the old poor, not much of the new poor, because what we have seen that not much of acknowledgement in the policy discourse about the emergence of this large number of new poor in Bangladesh. So government tried to use the existing tools, the social protection programs. There was not much innovation in the social protection programs to address the new kind of challenges or something which the new poor people they were facing, especially in the urban settlement, the urban informal sector. We have seen a huge, what we call the reverse migration, going back to the rural areas, trying to cope up with the kind of adverse situation. And we did not see that kind of policy response from the government, despite the fact that government expanded its social protection program quite significantly. And also we have seen that there was a kind of institutional challenge in addressing or reaching out to the poor people. There are many leakages and several other issues, especially that these are all old age, very long-standing problems in disbursing the social protection programs. But now on the farm side, especially where we try to see the kind of recovery of the farms through our repeated surveys, what we have found that especially the small and medium enterprises, they have been actually left out in this whole government support process, especially though the stimulus package which was announced was quite large in the context of Bangladesh economy, more than 4% of the GDP. But the large chunk of the stimulus package was actually enjoyed by the large and medium firms, whereas the small and micro and small enterprises where they were kind of left out. And there were some serious institutional challenges, to reach out to the micro and small enterprises through these formal banking channels. And we have seen that we repeatedly from SANEM and some other think tanks, we raised this issue. I think one fundamental lesson what we learned from this during this process and also the kind of policy responses is that despite that there are serious issues with respect to the institutional deficiencies in the health sector, in the education sector, even in some other financial sector, we have seen not much progress in undertaking some reform measures in addressing these institutional challenges. I will just sum up by saying that because if I start talking on the institutional challenges, it will take much longer time. What I observe that when it comes to institutional reform, we see there are two issues. One is that there are actors who have interest in undertaking institutional reform, and there are also actors who have influence in undertaking reform. But there is no kind of matching between these two types of actors. The actors who have interest, they don't have any influence. And the actors, those who have influence, they don't have any interest in undertaking this kind of reforms. I think there is a kind of deadlock in here, when you talk about this health sector reform or financial sector reform. Very finally, what I also, I'd like to touch on my third question, and probably I'll take a couple of minutes, is that how will COVID-19 actually transform the economies and the societies in Bangladesh? And it's not the lesson what we learned from Bangladesh. It's not only applicable for Bangladesh. I'm quite sure that that will be kind of a lesson for many of the developing countries as well. The point is that what we observed, even not only from an economics perspective, but also looking at the research on COVID from medical science and other research as well, that COVID is here to stay. It's not really going out very soon. That means we have to factor in COVID in our development strategies and development policies. So I think there is a kind of misunderstanding that when we look at our economic policies or some of the development policies, we think that probably COVID will go away soon, or in 2022, probably that is the end of COVID, and then we'll start going back to our normal process. But my view is that we need to factor in COVID probably for much longer time than what we thought. And for this, we need to devise our development strategies, in that way. For example, when we are observing this very new kind of wave now in Bangladesh and in many other countries, I think there is a kind of struggle and very kind of hesitance among the policymakers that what to do, whether shall we go for lockdown or shall we go for shutting down the economic activities, or what to do, especially even educational institutes and many other things. What we did not observe, and that is something I think extremely important, that during this COVID over the last 2 years or so, that we did not see much effort to develop sector-specific or area-specific protocols to deal with the COVID situation. Since we have the understanding that COVID is here to stay for long, we actually devise our plans and protocols to stay with that for long. And that's what we have not seen much. But I'm hopeful that we are learning, and with respect to addressing the economic challenges, institutional challenges, and social challenges, and some of the health-related challenges, probably these are the need of the day, that we need to develop these kind of protocols and implement them properly. Over to you, David. Thank you so much.
Thank you, Salim. Thank you. And thank you to all three speakers. So very interesting. I'm going to try and put some thoughts and questions to all three of you now, if that's okay. And then we'll go and take some questions from the floor. I mean, it seems to me that COVID, when it occurred across the world, this incident, this event, that no society was going to escape harm, that there was going to be some harm caused either directly by the virus or indirectly by the control measures that were required to try and prevent transmission. And, you know, we can also see that the virus has a differential effect on populations by age, by socioeconomic group. And similarly, the negative impacts of the lockdown measures also have a differential impact across different segments of society. And I guess the question I want to put to all three of you is, with 2 years worth of hindsight, now that we know much more about the virus and the impact of the virus on mortality and health, but also we have some idea now also of the impact of the various lockdown measures, the impact of the closure of schools on children, and so on and so forth. Do you have a sense of the balance between the efforts to protect the population from the virus and the collateral damage caused by those measures designed to prevent transmission? What can we learn, 2 years into the pandemic, with the benefit of retrospective hindsight? I don't know if you feel able to answer this question, because it's a very difficult question. But I'd like to just hear your thoughts on that. Caroline, Brunah, would you like to have a go at commenting on that or answering that question?
I can go first.
Sure, thanks.
All right. So, I mean, in hindsight, I think we've not fully grasped the impact on how this particularly has.
Oh dear, we've lost Caroline. Hopefully she will come back. Bruno, would you like to say something while we wait for Caroline, hopefully, to come back?
Yes, yeah, this is a very difficult question, and what we have been discussing is how the government should have acted more to prevent the collateral damage of the measures to protect the population against the virus, the social protective measures, and how the government failed in doing this, and how people, especially from slums and poor communities, had to develop themselves ways to prevent this collateral damage. So especially women, we are seeing how they were able to create several solidarity nets, like to donate food and everything that the population needed. They started doing masks, sewing masks to distribute. So they started to do all that the government should be doing to prevent this collateral damage. And yeah, I think that's it. Hope I was clear. Thanks, because the language is difficult for me.
Yeah, I suppose Brazil is quite interesting because you have a very particular government that adopted a very particular approach to the pandemic, in the sense that it didn't do much to mitigate transmission of the virus, nor did it seem to do much to try and also kind of provide support for some of the collateral damage caused by, some of the measures that were implemented in terms of lockdown measures and the like. I mean, there were some lockdown measures in Brazil, wasn't there? Was there nothing like that? Was it really very much a policy?
It was. It depended of the city. Each city adopted there was no unified coordinated action, and like in where I live in Belo Horizonte, we had when it was worse, the services closed. Only essential services remained open sometimes, but we hadn't have a real lockdown here in any place, as far as I know. Maybe some cities, but I don't know. the country is so big.
Yeah, thanks. Salim.
Yes, no, I think definitely this is the question which we have been struggling to get the answer over the last 2 years almost. And I think the policymakers, they're also looking for the answer. The choice between life and livelihoods and what kind of policies need to be taken, and whether lockdown is the right kind of answer. We actually had 2 major episodes of lockdowns in Bangladesh, if I'm not wrong. There are some small intervals here and there too, but 2 major episodes which was kind of prolonged. But now eventually I think there is a kind of understanding that lockdown is not a very popular measure. Drawing lessons from those 2 lockdowns, that though they were supposed to be very strict lockdown, but they were not in practice because of various reasons. The implementation capacity is not that strong, and also the awareness level of the people, need of the people, you can't really enforce that kind of strong lockdown. But despite that, there are some episodes of lockdowns where major economic activities were halted. But now I think what I understand that with my engagement with the policymakers and the general understanding is that lockdown is no longer a popular option. So the economic activities will go on, but side by side, we have to accept this kind of reality and to enforce the kind of health and hygiene practices as much as possible. Despite that, we all know that there are serious issues, how to enforce these health and hygiene practices, given the kind of informal and the kind of very dense population, as well as the lack of awareness of the population. I think that's a fundamental question, of course.
Yeah. I mean, I was going to ask that question as to what you feel is actually feasible in dense, under-resourced areas in terms of controlling transmission, and particularly if a variant like Omicron enters a country, as it inevitably will, I suspect, making it even harder to prevent transmission. And then of course you run the risk of actually having the worst of both worlds, both the effect of the virus and potentially the negative effects of lockdown measures, which may not be actually that effective in the long run with regards to transmission control.
You're very much right, David. Actually, what we are observing compared to the last year, when there was that Delta variant, it was very little, and then the effect on lives was so prominent. Here now, gladly and actually fortunately with the Omicron, it's not that little, and probably many, almost what I hear, talking to relatives, friends, almost all families and houses, they are being affected now with the cold, so-called, but they are not going for any testing. And I'm quite sure that if they go for testing, they'll be tested positive. But it is now being kind of accepted that since it's not really affecting much, probably let's have it and then go back to the normal life. But let's hope for the best, David. Yeah.
Good. Okay. One last question is really about the impact on the health services themselves. And I'm just wondering if there's anything we can learn, again, from the experience of the last 2 years. I'm thinking not so much about COVID, but a future pandemic. Should a future pandemic occur, what can we learn from the experience of COVID in terms of trying to maintain or retain health services, make sure that they keep going. You know, what can we learn about how we can protect our frontline health workers? You know, because we want health services to continue, we're going to have to be reliant on healthcare workers to come into contact with patients. They're very much on the front line. Is there anything that we can learn that, you know, to make things better? To keep health services going and to protect health workers from their increased risk if we want those health services to continue. Brunah? I think we've lost Caroline, unfortunately.
Yes, I think one of the main things that we are seeing is that the health services cannot forget all the other diseases that are going on. I talked about sexual and reproductive health, but also I'm studying dengue here in Brazil, and it completely disappeared as it stopped existing. So it is important to continue to think about this other diseases test, and also about health professionals. We saw a lot of mental health problems and fatigue, and I think that one of the things we are seeing is that we don't have enough health professionals in the country for this kind of emergency. So there is also we call the crisis of care. We need more care professionals, not only health care in general. So investing in this to be better prepared and stop cutting investments in health, in the public health system as in general. And yeah, I think that's it.
Thank you. Salim, have you got anything to say about health services?
Yeah, very quickly, David. Yes, one important lesson, what I think that is there, that a crisis like this, COVID situation, in a pandemic, the public health sector needs to be strengthened. And especially that has been the case in Bangladesh, where it has been very weak, and historically it's been very weak because of very low, one of the reasons is very low spending in the public health system. And what we have also observed that during this pandemic situation, the private health system actually kind of collapsed at the beginning. But then eventually they came up, and especially they had some arrangement with the public health sector. So I think one lesson would be how to kind of, face if another kind of pandemic comes, whether the public health sector is capable enough through its research, through its, infrastructure, health infrastructure, health professionals, to handle this kind of situation. And the second point, and this is my final point, is that it's not only the COVID. We have seen the problem, because during the COVID situation, what we have seen that the non-COVID patients also suffered quite a lot, and they were not really receiving right kind of treatments. I think these issues need to be settled and also need to be seriously looked at while we devise our health sector strategy for the coming days.
Yeah, certainly in England, where I have been living and working for some years now, there's also this issue of looking at the acute impact of COVID and the virus itself, with the more chronic impacts of the effect of collapsing health services for the treatment of chronic diseases. So the impact of the failure to provide good care for chronic diseases, or to provide prompt diagnostic care for cancers, for example, that impact may only take 3, 4, 5 years before it becomes fully apparent. So there's also an issue of how we measure the impact of COVID, both the direct and the indirect effects from a kind of temporal perspective, because the impacts of COVID are seen acutely, but some of the collateral damage will be only apparent in years to come. Caroline, you're back with us, I think. Are you with us? I can see you on my screen.
Sorry, David, I don't know if you can hear me.
Yeah, we can hear you. Do you got cut off as you were answering the first question. Do you want to carry on with what you were saying, Caroline? Okay, looks like we've lost Caroline again. Okay, let me take some questions from the floor.
David, the questions are in the Q&A in the chat box.
Yeah. So there was a question from Jenna, who is interested in learning about the different perspectives on the most important aspects of community-based approaches to COVID-19 responses. Brunah and Salim, is there anything you can say about community-based responses to COVID-19 and the problems associated with it? Brunah?
Yes, I talked about a little bit about it before. We saw a lot of knowledge being produced in the communities and in solidarity networks. We are still investigating this, but it's very interesting how they were able to create their own ways of coping, their own networks, their ways of identifying the families that needed most help, of going after funding of projects, different projects, also cultural projects in all kinds of different responses and against hunger, food distribution, mask distribution, and there are a lot of strategies being developed. Like there are real knowledge production in there.
And so you talk about solidarity, but was there also any kind of problems experienced with divisions within communities? I know in England, again, at the beginning of the pandemic, there was a lot of solidarity, communities coming together, but as the pandemic went on, that began to fracture. And there were some members of the community that didn't want to continue with lockdown. They didn't want to continue with wearing of face masks. And there were others that did want to continue that way. And that actually started to create divisions within communities. Is that something you also experienced in Brazil? And anything that we can learn about how to avoid that kind of thing happening?
Yeah, here there is also a lot of tension, especially because of different political visions, and this is in the whole country and in the communities. We have the same problem, and we are still trying to figure that out. I don't have an answer for that. It's really
it's another $1 million question.
Something that the communities are also doing is producing information about the viruses, because the government spread a lot of misinformation. So they produced their own material, communication materials, and radio programs, and all kinds of things to inform people about the problems.
Yeah. I mean, Brazil's quite unique in the fact that it was partly the government producing misinformation. Well, perhaps not that unique, but I mean, in most other countries, the problem has been not with the government information, but with information on social media and other platforms.
The researchers with the population trying to fight that. It's been hard.
Salim, anything you can say about community-based responses?
I think it was mostly on the kind of coping strategies, especially during the pandemic and especially during the lockdowns. What we observed that people migrated, a large number of people from the urban informal sector, they migrated to the rural areas. And what we are talking about, this new poor, they were out of the kind of government's, any kind of support measures. So some of our surveys, actually, they came up with the findings that part of the coping strategies was, a good part of the coping strategy was actually support from the friends and families and the networks and the communities during that hard time, where the government support was very minimal and probably non-existent. So yes, probably this is something what I can share with you from Bangladesh experience and from the survey results what we've got.
Yeah, thank you. There's another question here from Nadira to you, Salim. Those who want to influence institutional reform, if does not have interest, then what are the reasons behind? I'm not quite sure what that question is saying, Nadira, but I think it's a question about, maybe you can say a little bit more about what kind of institutional reform you think is required and what might block or facilitate that reform.
Yeah, actually, what if we take the health sector, for example, there are some very powerful groups in the health sector who are the real influencers, managing the health sector, managing the resources which in the health sector, and also probably they're the powerful groups, so starting from the ministries to different other stakeholders. But those who are really interested in having some meaningful reform in the health sector, they have genuine interest, but they are kind of powerless, or they don't have much influence in doing this health sector reform. The reason I'm saying the reform in the health sector is a kind of long-standing issue in Bangladesh. We have been talking about the reform in this sector for years, but despite that, we haven't seen much progress in that front. So the issue is, on what we have observed, drawing experience from other countries and several other areas too, when you have a situation like this, where you can't match the actors which have influence, but they don't have interest, but the actors who have interest, but they don't have influence, you need to bring in or introduce some new set of actors to who have both interest and influence. And to introduce those new set of actors, actually, the government has to step in quite very strongly, kind of exogenous shock into the sector for undertaking reforms. So that's what I tried to mean, and I have papers on that too. So I'll be very glad to share with us if participants they want to contact me. I'll be very happy to share those papers with them. Thank you.
Thanks.
I wanted to point out Caroline's been in touch. She's out of power, but she's willing to respond through text and asking us to share if there's any particular questions around. There was one around support from communities. She has a response. Can I read it out? I'm sorry, but I think that's only
thanks.
So she said support from communities in the Nairobi or Kenya context. Yes, there was multi-sectoral support from NGOs working in slum communities, but it was uncoordinated and not sustainable because there wasn't the kind of resources or other kinds of external support required. So that's one response, and I'll come in when required. Thank you.
Thanks, Sabina. I'm just looking at a couple of other questions. Yeah, I mean, this from Pradeep is asking a really important question, similar to what I'd asked earlier, in the sense that he's asking that in some parts of the world, government was very strict in terms of imposing lockdown, but eventually failed to prevent the transmission of infection. If this is the case, do we have any reason to believe it was an effective measure? And I guess with this, there's also the issue of vaccines and, ensuring that there is vaccine coverage, because in many countries, the rationale for imposing draconian lockdown measures, which carried with it a number of harms, was that it was going to buy time for countries to be able to then roll out the vaccine. So I'm just wondering, with both Brazil and Bangladesh, and Caroline, if you can hear us with Kenya, whether the lockdown measures are kind of being titrated against the improvements in vaccine coverage, in the sense that as vaccine coverage goes up, there is an explicit and deliberate attempt to loosen the restrictions, in relation to the various lockdown measures.
I can very quickly tell about Bangladesh. Is that we had some hiccups in vaccine procurement of vaccines, and we all know that. Initially, the way it was planned, the delivery was not there much, and then it was delayed. The vaccine came, much at a later stage, but the infection rate was going up, and the government, I think, we can't blame the government whether they were taking the right decision or wrong decision, because there was not something in front of them that you have some thing, and because other countries are also following the same kind of measures, the lockdown measures. So it was easier to follow the lockdown measures rather than doing something different. So probably they followed the same strategy, but at the same time, David, you were right. Probably they were also waiting for vaccines, which actually got delayed. But I think it was more of a kind of natural phenomena, through which that infection rate went down, rather than the vaccine which came to effect, because in any case, the vaccine coverage was not that great to begin with in Bangladesh, and then still we are struggling to cover the major part of the population, but the situation has improved quite a lot over the months. Thank you.
Can I respond for Caroline?
Yes, please, Sabina.
So a couple of comments. So because we work together in the same larger project, I don't know if this is the actual response, but the measures that were taken were quite rigid and didn't take into community needs and priorities. The vaccine, I think responses also, I'm not sure, as coordinated, particularly around rural versus urban prevalence. There was a question around disaggregated data. There is no data available. Urban counties report higher numbers of cases, with Nairobi, the capital, reporting the highest numbers, but there's no case data on slum versus non-slum available. Caroline has on other forums shared the strictly biomedical approaches to lockdown, which didn't take in the personal, economic, social costs. So I just wanted to share that. Thank you.
Yeah, thanks. Brunah, do you have anything you want to add?
Yeah, in Brazil it's different because we didn't have real lockdown, but there was some closure measures that were important, comparing the cities that adopted them to the cities that didn't adopt them. And here the vaccine rollout is very successful, but so now we are relaxing all these measures because of the vaccine coverage.
Right. I'm slightly surprised in Brazil, where you have an authoritarian government and regime in place, that they didn't actually see COVID as a great opportunity to implement control measures, not necessarily for controlling the virus, but for controlling the population.
Yeah, but they denied. Yeah, it's difficult to explain in another language, but we suppose that the government wanted people to die. That's basically
right.
Yeah, that's why it didn't care, because didn't care.
Okay. I'm just looking for more questions. I'm also maybe interested to know from a kind of socioeconomic perspective. We've seen at the global level, and we've seen certainly in countries like the UK, that the impact of COVID, both the direct and indirect measures, has been to actually increase socioeconomic inequality. So, there's been lots of reports about the emergence of COVID millionaires as a result of some of the responses to COVID. In Brazil and Bangladesh, is there any data that points to the way in which over the last 2 years wealth has either been redistributed or has further concentrated in the hands of the already wealthy? Is any of that data available?
I can quickly step in. In Bangladesh, yes, our survey data actually showed, because we had the advantage of comparing pre-COVID and post-COVID situation. The pre-COVID, what we had, this 10,000 household survey back in 2018, and 6,000 household survey. by end of 2020 or early 2021. And we found that actually looking into the standard measures of inequality, the inequality increased. So that is the one aspect of inequality, especially the income inequality or expenditure inequality. But more fundamentally, what we have seen that though there was an effort to include the students through online education system, only probably around 20% of the students, they could actually participate through this online education system, and the rate was very low in the rural areas and for the marginalized population. So this education inequality, that is really a significant impact for the future generation and the kind of future productivity. I think that impact is going to be lasting for long, and then we'll be seeing more of this impact in the future. To what extent these educational inequalities or disruption is actually affecting other aspects of economic lives.
Yeah, I think that's such an important point, that that digital divide and its particular impact on children and education. I mean, has this kind of catalyzed government action to improve access to information communication technology, rolling out this to schools in rural areas, etc.?
There were some provisions by the government to provide some kind of internet facilities, but actually compared to the need, the supply was very limited. And so that has been the kind of struggle on the government and the educational institutes. They have been struggling, since the beginning, very beginning. And they came up with some ideas like submission of assignments or, distant learning, just the students, they will prepare assignments. But that did not work much compared to the kind of what we hear from the government, especially some of the independent evaluation. They are showing that the assignment or some of these initiatives by the educational institutions did not really work to the extent what compared to the expectation.
Yeah. We've got a question or a comment from Simonthi Barua, really making a comment about the USA. The USA has the most number of infected cases and deaths. What made it go through such a massacre in spite of being the world's most powerful country? What are the lessons that they can learn? And I don't know if you want to comment on that, either Salim or Bushra. Salim or Brunah.
My quickest answer is don't follow USA. Yes, probably you are sitting next to USA. You can close to USA.
I think Brazil and USA are very similar in some ways, like in the science denialism and fake news. It's very similar in this aspect. I think that has had a big impact in this.
Yeah, I mean, I think it's also worth remembering that the demographics of the USA are very different from many other parts of the world, with high prevalence of obesity, but also higher an older demographic. So mortality rates would be higher, partly for that reason as well. And it seems like Latin America, again, they seem to have been affected much more severely by COVID. Populations in Latin America seem to be much more badly affected by comparison with populations in Africa, for example. From what I know, we still don't quite understand why, but there might be something about differences in the kind of immunity of populations in different parts of the world. I don't know if anyone else is on this call who could listening to this session who could respond to that. The variation in infection fatality rates from region to region.
I was going to ask David, we have Professor Richard Cash who's done extensive work. If you'd like to say something on the chat box. He's looked at the challenges with just adopting models from the West. I don't know if he's still with us. If you are, Richard, we'd appreciate you adding any comments to everyone in the chat box. because I don't know the technology of how to unmute colleagues or how this technology works. I'm very behind on that. But while we wait, if Richard's around, we'd appreciate you commenting from your experience.
Here's Richard, and
Okay,
from what I
great.
can see, he's unmuted.
Okay, Richard,
Richard, are you there?
this is Dr. Richard Cash.
Can you hear me?
Hi, Richard.
Yes, we can.
Fabulous, thank you.
Thank you very much. It's a fascinating discussion. I think, going back to the last question, I think that the reason that the U.S. has had so much is exactly what David said. We warehouse our elderly, so they were very susceptible to mass deaths. The average age of death in the United States is still in the 73, 75. So it's really affecting those populations. Obesity, I think, is a huge issue. In terms of Latin America, I think it's very interesting to say, compare Peru to Ghana, both similar populations, but Peru has a much more urbanized population, an older population, a more obese population, and all of those have created a 20-fold difference in mortality per million people. So I think that demography plays a huge role, and also how people live. In most of Bangladesh and in Kenya, the elderly live at home. There are no old age homes. There are no chronic disease facilities, so that the spread occurs within a household, not within a mass group of people. And I think that has also contributed to lower mortalities. My earlier comments are, though, that, and Vikram Patel and I wrote about this about a year and a half ago, is that the demography and other factors were not taken into consideration in the general response that countries took. And that even today, I think that the West is a good example of the West, and South Asia has its own issues, and Sub-Saharan Africa has its own issues, as has been well articulated by David and McCoy and David Nabarro. And that was not considered initially, unfortunately, because most of the morbidity, economic and medical, is not from COVID, but from our response to COVID, unfortunately. But we're learning. I'm not sure that, Salim, I would say that because this is now an endemic disease, there are lots of endemic conditions that cause colds and upper respiratory infections and so on, which do not bring countries to their knees. And so, and it may well disappear. I mean, the 1918 flu disappeared, and we have no idea why it disappeared. It just disappeared. That is still possible. We don't know, but it's still possible. Sorry if I've gone on a bit, but I'd like to thank all of the participants and the moderators. It's been an excellent session. Thank you.
Thank you very much, Richard. That was extremely helpful.
And Richard is joining us from the States, David, so I don't know what ungodly hour it's over there, but thank you for sharing your wisdom.
It's only 10:30. It's only 10:30 in the morning.
Oh, is it? Okay, I have no clue, but thank you so much for sharing your wisdom. I'm going to barat now. Thank you.
Yeah, but I mean, I think if we're talking about lessons learned, that really must be one of the most important lessons to learn, that a response to a global pandemic needs to be much more differentiated, much more contextualized than it has been with COVID. Right, I think we're kind of nearing the end of this session. I'm going to just ask Salim and Brunah if they want to make any final last comments before we close.
David, I'm fine. Thank you. It has been an
You're
excellent
fine?
session. Thank you so much.
Okay, thanks. And Brunah?
Thank you. I'm fine. Thank you very much.
Okay. Sabina, have we got any comments from Caroline that you want to communicate to the rest of us?
At this point, she's completely lost on all connection. So she shared whatever she could. But if there are
Okay.
specific questions, participants can write to Onubab and she can respond to them at a later stage. So I think we can wrap up. Thank you, David, for managing this. And thank you, Richard, for coming in. Wonderful. And thank you to Salim and Brunah.
Okay, well, I guess we will put a close to this session. Thanks again to all the speakers. Thanks to the organizers. It's midnight here in Kuala Lumpur, so I'm heading to bed. So good night from me and goodbye.
Thank you, David. Thank you, everyone.
See you tomorrow at the 2 sessions. We're starting at 7 p.m. Thank you, everyone, for joining us today. Just the links are in the chat box. Good night. Thank you.
Thank you very much. Thank you.
Thank you, David.
Thanks, Sabina. Pleasure.
That was, you know, sorry about the whole poor Caroline, because she was like, I'm missing all
poor
the
Caroline, yeah.
discussions, but, you know, I thought we raised some very important issues and they were managed to